Thanks, Helen, and thanks for the opportunity to chair this. And this is a fantastic group of speakers we've got to introduce tonight, and then have a panel following that. And the first speaker is someone who I'm sure you all know well, but I'm really going to enjoy introducing, and that's Professor Chris Baggerly. And in the little bio here, it actually doesn't mention the most important thing about Chris, and that he's a Flinders University graduate. And actually Chris was in the first year that went through the Flinders University Medical School when it opened. And I think at the time he went through, Flinders Medical Centre wasn't even built. So he started at a medical school without a hospital for a little while. Chris has gone on to bigger and better things after moving from Flinders into the area of quality, and now into he's the Chief Medical Officer for Australia and the Principal Medical Advisor to the Minister and the Department of Health. He holds direct responsibility for the Department of Health's Office of Health Protection, and as I mentioned prior to that, he was the Chief Executive of the Australian Commission of Safety and Quality in Healthcare. So he really has worked in this area for a long time. We all know he's a great guy, and we're really looking forward to his talk. Thanks, Chris.
Well, thank you, Steve, and good evening, everyone. I'll speak up so I can drown out those noisy folk. Yeah, I did have the privilege of graduating from Flinders, and in the first year, the first intake, I had an important task to do, because I thought, wouldn't it be good to be the first to graduate from the new medical school? Not the first to graduate first, you understand. That's a surgeon by the name of David Watchow. But there was Adams and Anderson, who were very fine people. And I worked on them for 5 years to make sure they deferred for a year. And then Baggerly was the first graduate. So there you go. That's my most significant achievement, I think. But I'd like to thank the Robinson Research Institute, SA Health, the Women's and Children's Health Network, and SAMRI. And isn't it great to have Steve here in South Australia? We are just so blessed. And also particularly Associate Professor Helen Marshall, found her in the red coat, so that was good, for inviting me tonight. And as a fellow South Australian, I was pleased to be involved, because it got me home in the middle of the week. I still live here in Belair, and I've wangled a few things, so I don't have to go back to Canberra till Sunday night. So that's a beautiful thing. But by the way, I would like to acknowledge the traditional owners of the land, the Kaurna people, and their elders, past and present, and pay my respects to them. Now, I write the vast majority of my talks, but this one had a few technical things in it, so I need help. So I've changed a few things, but I didn't change this one, because I had to ask whether the Minister had made any announcement about the 2016 influenza season, and she hasn't yet. So you'll have to do some reading between the lines when the time comes. Now, Melissa Peel spoke to you earlier, and I was there for question time, and I saw Melissa beautifully handle a question about the NIP for influenza next year. Well done, Melissa. I'm not sure I'm as delicate as you are, but you're not in any trouble at all. We'll see if I can get out of that. And what I want to do is just build on some of the issues that Melissa has raised. She was kind enough to send us her presentation. I was in Sydney today, read it on the plane, crossed out. But I really don't want to repeat what she said, but just add a few things. Her slides are much prettier than mine, and she had 4 logos on her slide, and I've only got the 2. I'm really quite jealous. But now, look, we've had several discussions and presentations about national immunisation coverage rates, and Melissa, I think, covered all the age groups on one slide, and Adriana. She provided excellent data on the Aboriginal and Torres Strait Islander children, and her presentation and that from Daniela were really just superb, weren't they? So look, you can look here. This is the y-axis is a bit of a cheat because it starts at 85, goes to 94 to emphasise the differences. And what you will see on the left, because it doesn't show up on the x-axis, on the left two columns are well, you see it on the right-hand side there, the national data. The middle two columns, South Australian data, and the right two columns are the data from the first quarter of this year, which I don't think you will have seen. And I won't go describing it to you because you can absorb it. I must admit, when I first saw the numbers, I thought it was showing South Australia better than national average. But have a slide of that, and sadly we just lag a little bit there, a little bit more there. But I think, when we are looking at margins around 90%, I mean, this country does extraordinarily well, I think, and we should never underestimate how well we are doing. And of course, it does get harder. And particularly with 2-year-olds, the inclusion of more vaccines in the criteria to be assessed as fully immunised just makes the task harder and harder. So that it stays up this high, I think, is extraordinary. And 5-year-old immunisation here, and South Australia again does very well. With regard to adolescent vaccinations under the NIP, we currently only record vaccinations given under the HPV vaccination program, as you know, and the results so far are good, with the 3-dose coverage for females turning 15 in 2014 at 73%, and for boys it was at 60%. So the numbers are good. Now, this was largely covered by Melissa, and so I don't want to go over that. I think what's important to the Department of Health in relation to improving immunisation rates is the communication process. That's what we've been focusing on. And we've got funding to develop a range of communication activities. And you've heard about the SARA project, the tools and resources to be developed by NCEAs, and I think Julia's going to talk about that. So I won't go to that any further. And we'll take credit too for the incentive payment for immunisation providers for that catch-up process, that $6 one, which Melissa spoke about. Again, she covered the upcoming vaccines, and you heard about the additional 18-month pertussis dose to be added. The rollout of the vaccine is expected to commence in late January, but that's subject to the availability of adequate supplies, and we're being advised that supplies are pretty tight. Is that what you're finding? I think 18 months for getting vaccinated. Don Roberton spoke. Is Don still here? He's gone? He couldn't go and visit his new granddaughter or son? Grandson, until he had the jab, the cocooning jab. So we're certainly soaking up the vaccine as much as we possibly can as a population, and supplies might be an issue. And I got a note here that says, for me to say, I will be writing to vaccination providers early next year with further details on the rollout of this vaccine. The notion I sit there and write all these letters. You'd think I'd spend all my time writing personally to vaccination providers and to parents, and you are all too young. Well, some of you are not, but I also write letters to the 50 to 70-year-olds on an entirely different matter, congratulating them on their significant birthdays and asking them for a sample. And if I won't say, if you don't know what the sample is, I won't spoil your dinner. My wife got pretty irritated when she got a letter from me that I hadn't bothered to sign personally. And she said, you know what you can do with your sample. It was just a tense moment, that was all. We're okay, really. In relation to Zostavax, again, you know that it's going to be available from 1 November 2016, and some people ask, why does it take so long? Really, once a new vaccine is approved under the program, it usually takes about 12 to 18 months from receipt of government funding approval to implement, if we do the right things by a whole range of people. You need the activities, you've got to procure the vaccine, you've got to plan for the vaccine safety surveillance, develop appropriate communications, and work with the states and territories regarding implementation requirements and timing. And that's important. And I think the HPV vaccine was introduced at a pretty rapid rate, which put the states and territories under a lot of pressure when that happened, and we don't like that. And of course, in the case of the Zostavax, the time's also required to develop and roll out an adult vaccination register. Now, you've heard about No Jab, No Pay, which is an initiative of the Department of Social Services. Did you hear that? Got that? And the broad details have been discussed. By way of an update, the bill passed the House of Representatives last Tuesday, but remains before the Senate Community Affairs Committee, which has got to report back to the Senate by the 9th of November, which isn't long. So those of you who are going to present, got to make a persuasive case, and pretty quickly. The Department of Health has got responsibility to communicate the implications of the changes to vaccination providers, and particularly on their role in giving catch-up vaccinations. There was a really important question just before dinner on data quality, and thank God Kirsty Faishney answered a mobile phone at dinner time, because I rang. I said, I'm in trouble here. We know there are data quality issues. I know that each flu season, when we follow up each child under the age of 5 that was given flu vax, we know that the reports of flu vax are almost always data entry problems. So data entry is an issue, and the advice that she gave was that the one that's most time critical, which is the child care benefit, there's a grace period of 63 days. And if obviously a parent thinks, well, my child's been vaccinated, they can then have time to go to their GP or go to the state public health unit, but ACIR will have the resources to be able to respond directly to the state units or to the GPs to provide the information. So there's an understanding this could be a problem. Now, the Department of Health is procuring catch-up vaccines under this measure, and so that process commenced on the 15th of September, closed on the 12th of October. It should be finalised by the end of the year. In relation to No Jab, No Pay, I was sent an email today, which is an exciting thing to get an email. Don't get many of them. From a couple, I won't name their names. I've got no idea. I've never met them. Not sure exactly where they're from. But it started saying, we understand that you are a proponent of evidence-based medicine and we applaud that. That's where I should have stopped reading the email, because it went on and on. And they've sent me in this email 130 independent scientific research articles and excerpts from highly qualified doctors and scientists. And you could imagine what's about how harmful vaccine ingredients are and so on. And I'm not going to go into detail on that, but the one sentence they said is No Jab, No Pay is screwing with people's lives. You either go for the money or the safety of your children. And I wouldn't be surprised if there will be more public discussion and debate about what the no jab, no pay policy means. And I know, Julie, you're thinking of that. But I think there seems to be overwhelming political and public support for that measure. Now, there's also a question about the registers, and I think it's important to point out to you, in case you weren't aware, by 1 January, the register will be expanded for children up to 19 years of age. But on the 15th of October, just a few weeks ago, the Australian Parliament passed the new consolidated legislation for national immunisation registers. And that's the first of the register for children up to 19 is the first in a series of register expansions. And so by this time next year, it will become an Australian immunisation register. I think that was Danielle's big hope. And at the start of the 2017 school year, it will expand to have the Australian School Vaccination Register. So that, I think, is a really important development. It's been called for by folks such as yourselves for a very long time, and it will enable vaccination providers to have secure access to a range of due and overdue reports and new opportunities to identify areas of low coverage. So, and of course individuals will have access to a record of all vaccines recorded in the register. So that is just a good thing. And certainly immunisation is not a party political matter. It's a bipartisan discussion in Canberra. Now, influenza, we all know several things. We had a significant flu season. It is said that the severity was moderate at worst during 2015, but there are a lot of people recorded as having influenza. For this year for the country, influenza B, there were more B strains than A strains infecting people. We know the trivalent vaccine has 2 A's and a B. The quadrivalent has 2 A's and 2 B's. So the 2 A's and a B was a good match, but there's about, and it varied between states and territories, about a quarter were the influenza B that wasn't covered. So the government has understood and heard and listened to this issue. I noticed Melissa's report on the 2016 program for South Australian healthcare workers, where they will have the quadrivalent vaccine, and using Sanofi Pasteur, the flu quadri product. We know that GSK and Sanofi both make the product for adults and be available on the NRP. So I'm not in a position to preempt any ministerial announcement, so I can't advise on the 2016 NRP program for influenza. But I think there's a reason that flu quadri is being used by South Australia for healthcare workers, though, and if you can't work that out, then you'll go tweeting things and then I'll be in big trouble. So we'll just leave it there. The other thing is that the NIP flu contract will be negotiated for the start of the 2017 year, and that process will be going on. Now, I think questions will come at panel time. Hopefully I didn't overstay my welcome, Steve, and I've got Kirsty Faciony. She's last day today, but headed up the immunisation branch. I've got her on speed dial for any tricky questions you've got. Thank you.
Thanks very much, Chris, and there will be a lot of opportunity for questions when we get the panel up on the stage, but we have promised Chris that he can ring a friend if he can't answer the question. So our next speaker is Associate Professor Julie Leask, and I chatted with Julie earlier because it says here Julie is a social scientist specialising in immunisation, and she wanted to be reassured that I knew what a social scientist was. And I did reassure her that I knew a little bit about social science, and I think Chris has highlighted actually in his talk the importance of social science in the area that we're dealing with today. and actually the title of Julie's talk indicates that some of the issues that Chris was talking about in regard to no jab, no pay, etc., are important issues in terms of communication, in terms of understanding the social science of immunisation. So I think it's terrific that Julie's here, and she's an associate professor and sub-dean in the School of Public Health at the University of Sydney, and she established the social science unit at the National Centre for Immunisation Research and Surveillance between 2002 and 2014. So, Julie, we're looking forward to your talk.
Thanks, Steve, and I'd like to also acknowledge the Kaurna people, the owners of this land, and thank you for the invitation. I'm talking about communicating confidence in immunisation. I hear that last year there were some requests to cover communication and vaccine hesitancy issues. So we'll try and cover that. And I'm going to talk briefly about coverage, put vaccine hesitancy in context of non-vaccination in general, and then focus on health professionals, because I understand that most of you are immunisation providers. There's some researchers here, but so I'll have a bit of a provider focus. And then some thoughts about communication with vaccine hesitant parents, and I'll be focusing on routine vaccination for under 5s with some forays into HPV and possibly maternal. But the most important things first are the acknowledgements, and I work with a great bunch of people. A few of them are here who work closely with me, Kerry Wiley, Margie Danchin, and other names you see there. And it's just a privilege to work with fantastic people, as I'm sure many of you know. So, what about the immunisation coverage gap? For 12-month-olds, we have an estimated, if you account for underreporting to the register, we think it's about 93.7% fully vaccinated. It could be a bit more, could be a bit less. And there's a proportion of parents who lack the opportunity, the access to the services. There are practical factors getting in the way. They support immunisation, but it's a practical logistical barrier that stops their children being up to date. And there's also a proportion who don't accept vaccination, so they either vaccinate not at all or just partially. And it's that group that I'm going to focus on tonight, as we hear those other people obviously enjoying lots of wine. So we've heard a lot about vaccine objectors, this big rise in vaccine objectors. We've even heard vaccination rates are declining. Vaccination rates for children have remained stable over the last 10 years. Vaccination objector rates have risen. We think it's because of an increase in awareness of capacity to claim the vaccine objection exemption in order to receive family assistance payments. See that red line at the bottom? That's that 6-fold rise. So in absolute terms, it's quite small, but in relative terms, it was a 6-fold rise. So our objector rates are now at 1.52%, so they've come down a little bit. And obviously, from next year, we won't even be measuring them, so we won't know what they are. We won't be able to monitor them. And that's a problem. We need to keep monitoring acceptance of vaccination somehow at a national level. The thing is that even though that looks like a small group, it masks some real issues. Silent refusal. Some people don't register their objection to vaccination. We think you could probably add another 1% or so. Clustering of vaccine refusers in particular regions, the darker regions that you see here, particularly regional areas where there are alternative lifestyles that are more common. Higher hesitancy rates, so people might be still vaccinating fully, but they might be quite hesitant. And those rates might possibly be increasing, but we don't really know because we don't really survey vaccine acceptance nationally and monitor it yearly. And there's a potential for rejection of a certain vaccine in a vaccine safety scare, like we saw happened with the UK and the rejection of the MMR vaccine, which led to a big measles outbreak there. So this mum who's making the decision to vaccinate her baby is at the centre of all sorts of external information about vaccination. We're really familiar with this. We've got issues like the MMR scare. People are still worried about autism, even though it hasn't really affected our rates at a national level. People hear about adverse events and wonder whether they're caused by the vaccine. They worry about the ingredients in vaccines. Even this Facebook page is a way for non-vaccinators to access varicella, so that their children can become naturally immune from varicella disease rather than have the vaccine. So social media is full of all sorts of anti-vaccine radicalism. And then there are stories like this one, where a mum whose daughter was well one day and sick the next, and an HPV vaccine happened in between. And she says, very compellingly, the only thing different about that day was that shot. These are really compelling stories. What do they do to people? Well, let's unpack this a little bit. In fact, most people unquestioningly accept vaccination. They don't think about it, they just go ahead and do it. And of course, you have experience with these parents. Then there are those who cautiously accept it, who have minor concerns, hope nothing goes wrong. No, there are some risks like with any medicines. And that's a pretty large group as well. There are hesitant acceptors who vaccinate but have a lot of questions and concerns and deliberate quite a lot before they go ahead. So these groups all vaccinate fully. Then there are hesitant parents who delay or select out certain vaccines. They might delay the Hep B birth dose or the MMR vaccine. They cherry pick the schedule. So they vaccinate partially. And then there are decliners. So they either never did vaccinate or they no longer vaccinate, often because of an adverse event that's put them off and scared them. Those who don't vaccinate to start with often have very strong beliefs about the way they should maintain their child's health. They're sceptical of orthodox medicine, and vaccination sits within those belief systems. Parents can change their positions over time, particularly with the influence of people like you. And what we want to see is a shift towards acceptance. People don't have to unquestioningly accept vaccination. It's quite normal to question any medical intervention. But we do want to see compliance with the schedule because we're very confident in our vaccine program in Australia. It's safe and effective. And that pyramid actually, if you look at it in population terms, we estimate it looks a bit more like that. So most people are acceptors, and then the hesitant who either vaccinate or delay or don't vaccinate at all are that group, those three bars at the top. Anti-vaccination activists are out there, we all know they're there. They don't completely superimpose the decliners. So parents who decline all vaccines aren't necessarily loud, out and proud activists. But there is some overlap. And also some of those activists are people who are wanting to spruik their alternative therapies, or they've got grown-up children and they have stuck with this anti-vaccination activism. So that's where they sit. So let's unpack this a little bit more. Declining parents are a small group. They're influenced by their communities. Some of them do change. We hear from providers in our research. If a trusted professional talks to them, particularly with that opportunity that's been afforded by the conscientious objection form signing, or if they reappraise risks, such as if they travel. Attempts to persuade them with facts can often backfire and actually make things worse because they then rehearse their arguments against you and become more entrenched. They're more mistrusting of medicine and government, and trust is a huge theme that runs through my talk tonight. And they raise broader narratives like these ones, the idea that vaccines are synthetic, toxic chemical cocktails that cause all manner of modern ills, such as those listed here. And they're part of a totalitarian agenda of government. So some parents who don't want to vaccinate are quite mistrusting and suspicious of government and sometimes quite conspiratorial in their thinking, as many of you might have experienced, particularly if you work in government departments and have to answer ministerials. So what about dealing with people who are very, very hesitant or don't want to vaccinate? Well, here's a little grab from the popular Doc Martin show. And Doc Martin lacks social intelligence, and his love interest, the beautiful Louisa, raises a belief about the MMR vaccine and a link to autism. I apologise for the sound and the video, but it's too worth showing to not show. Thanks.
Looking at Elliot, thought we might have had a measles epidemic on our hands.
There's not much chance of that. Almost all the children I've seen have been jabbed for MMR. There's only 2 or 3 mothers left in the village who haven't seen reason.
Maybe they're scared.
Maybe they're scared what?
There's autism.
No, there isn't.
Martin, a friend of mine took her son to the doctor. He was nearly 2, perfectly healthy. They gave him the jab, and he changed overnight, just shut down completely.
Not because of the MMR vaccine.
That's what she thinks.
Is she very stupid?
Look, it stands to reason that giving a child 3 viruses at the same time must increase their chance of some kind of reaction.
It stands to reason.
Martin, I have read about the studies linking MMR to bowel disease.
Well, there was one so-called study, but that's been refuted by people who actually know what they're talking about. And the hysteria that stopped people giving their children the MMR vaccine has actually caused an increase in cases of measles, which is a horrible disease.
Thank you, Doctor.
Thanks. So that's an example of a consultation that goes a bit pear-shaped. So the autism issue. Hesitant parents are concerned about the autism issue still. They're concerned about the number of vaccines, as Louisa mentioned there. They're worried about the immune system impact of vaccines on children and the ingredients, and that's what studies show us. About 1/5 to 1/4 of parents are worried about these things, even though most of them will go on to vaccinate. The schedule is becoming more crowded, as you can see. 1974, that was the schedule then. 2015 is the schedule then. So it is more complex, as we've heard. Parents who are very hesitant about vaccination want to weigh up the risks and benefits for themselves. So they want what they say is more balanced information. And they're sceptical of both very, very pro and very, very anti-vaccination information. They lean towards vaccinating if they have support to weigh those pros and cons, as we've found in our research. And they look to providers to address their concerns. Providers are very influential. I apologise about that graph, it's condensed up, but what it shows is this was a study of parents who decided to delay or not vaccinate, and then they changed their minds, and they took this sample, it's a US sample, and they asked them, what was the main reason you changed your minds? And the majority said information or assurances from a healthcare provider. This is just one study, but there are many studies showing that you are really important and influential. And so it's very important that our healthcare providers are getting education, updates like today, that their own hesitancy is being addressed, because some professionals are vaccine hesitant. And we also know that dismissive communication for vaccine hesitant parents is associated with non-vaccination. So what to do about addressing this thing called hesitancy? Well, hesitancy, as I said, on its own is not a bad thing. It's only negative or a problem when it leads to refusal or delay of safe, effective vaccines. So what do we do? Well, first of all, we remember that we need to put this in perspective. The bigger picture is that there's a bunch of people who have these practical barriers, and all the work that we've been hearing about today, really inspiring things that people are doing, is so very important. Data cleaning is unfortunately something that we have to do, and it's important so that we can then target the people who are truly not up to date. And all of these things you see listed here come with evidence that they make a difference to immunisation rates. So I'd like to highlight home visiting makes a difference and is cost effective, and it reduces inequity in getting children up to date with immunisation. Reminders, recall, you saw the closing of that gap. There is good evidence from overseas in Australia that reminders and recall help to improve vaccination rates. These things work. They're the practical things. Addressing a lack of acceptance is much more challenging. It's hard to unscare people. Thanks. So what do we do? Well, there are some great resources available to you. These are some of the resources from the Department of Health or from NCEA's fact sheets. The one in the middle, Parents Love, it's a what to expect after vaccination and when to call for help sheet. And all of those are available on the Department of Health website. Myths and Realities is very useful. That's been written for providers. The MMR Decision Aid, where we helped parents weigh up the pros and cons of vaccination, had a positive effect. Target the hesitant. Decliners of vaccines are often pretty entrenched. It is hard to change them. Some people can change them, but it's hard. The reachable attentives are an important group. These strategies have evidence of effectiveness, a positive recommendation. Parents need to know that you think vaccination is important for their children. Acknowledging emotion, if someone's worried, acknowledging their emotions it means they're more likely to proceed to process what you're saying, so they can understand what you're saying subsequently if you acknowledge their emotions and their concerns. Informing of common side effects and serious reactions. It's okay to talk about vaccine risk and put it in perspective. And motivational interviewing has been shown to work for the ambivalent in some areas like stopping smoking. And we're interested to see if it works with the vaccine ambivalent. So we're doing this study and it's called SARA, which is Support and Resources to Assist Hesitant Parents with Vaccination, but it's actually for providers. It's a communication package of strategies and resources developed for providers and involves a great bunch of people, Nina Berry, Margie Danch and Christine McCartney, Kerry Wiley, who are here, and others. And it's funded by the Department of Health NCIRS. So it's a structured process which involves identifying where the parents are at. Are they ready to go ahead and vaccinate? Are they very hesitant? Are they not going to vaccinate? And it's not worth your time spending half an hour trying to convince them to do so. Identifying the position, establishing flexible goals according to where they're at, using a guiding style and tailored strategies and resources. That's what it looks like very simply. I'm just going to rush through that because I want to talk about the resources themselves that we've started to develop, which we've called SKY, Sharing Knowledge About Immunisation. And these are some of the draft resources that are in the pipeline that you will hopefully see come out reasonably soon. And we will be doing further testing on them to make sure that they meet the information needs of vaccine hesitant parents and providers. They follow strategies around debunking, where we try not to rehearse the myth up front. We address the myth within the resource, but we don't state it up front. And we try to lead with a key statement as well. There are a number of areas where parents influenced, starting with when they're forming their views about vaccination when they're in high school. You know, our high school students are the parents of tomorrow. So some of us in researching this area are asking what can we do in high school to better educate young people about vaccination. Antenatal care, parents are often making their decisions then. Primary care providers, as you've already heard. Communities, how can we support people within the communities to be advocates for vaccination? Policies, it'll be very interesting to see how no jab, no pay plays out, what sort of intended and unintended consequences will occur, and we need to document that and evaluate it. And then routine and crisis communications, and I want to just briefly mention, in terms of adverse events signals, it's very important that we're prepared for these, because once the signal comes along, it's too late to start deciding how you're going to communicate. So now's the time to start preparing for that, what we might call crisis communication or event communication, with both parents and professionals, and have a coordinated approach to that at a national level. Pre-testing messages in campaigns is important. That's why we're pre-testing our SARA resources, working with champions, talking about protection. That's why we vaccinate. Let's remind people of the reasons we vaccinate to start with, and engaging via social media. So in summary, under-vaccination is caused by a lack of opportunity and practical factors, and a lack of acceptance. Acceptance is on a spectrum, and parents can change over time and with experiences with vaccination and with their children and their lives. Parents who don't vaccinate at all tend to be hard to shift. I think we should target the hesitant, the reasonable attentives, by identifying them and asking questions to find out what their concerns are and addressing those questions specifically in an empathic way. Adopting flexible goals and targeted strategies, debunking with care, being prepared for adverse event communications and signals, focusing on why we vaccinate, and prioritising trust. Trust is at the heart of people's acceptance of vaccination, and if we ever have to make a decision about what we do or say, we need to think about what will keep people's trust in the system and in us. Thanks very much.
Thanks. That was really terrific. Thank you. Our next speaker is Associate Professor Christine McCartney, and Christine is a paediatrician specialising in infectious diseases and vaccinology. And Christine actually has two very important jobs. One is that she's the Deputy Director of the National Centre for Immunisation Research and Surveillance, and we know that's important in the immunisation landscape. But actually, even more important than that, she's the Senior Editor of the Australian Immunisation Handbook. And I think we all know how important the handbook is, and what a terrific job the editors do. So welcome to the stage, Christine.
Okay. Thank you very much, Steve, and thank you to Helen and her wonderful organising team for this great event and the invitation. I'd also like to acknowledge the traditional owners, and it's just been really wonderful to hear, particularly from the Indigenous speakers today. So you may be thinking I'm a bit of a fraud. I'm a paediatrician talking to you about vaccines in the elderly. And I've been reflecting on this in the last few moments, and I thought, well, maybe it's because I got Chris's letter just 2 months ago. And it wasn't very welcome, Chris, I'm really sorry to say. But as I was coming here and I was thinking about that letter, I also thought, Ross Andrews' word, oh blast, I'm also now of that age where I could actually get the zoster vaccine myself. And so this was, doubly depressing. But I will tell you about why I think this is a fascinating virus and a really exciting vaccine. So I'm going to cover a little bit about herpes zoster itself, the epidemiology, complications from this condition, the vaccine, the program rollout, and a bit about what's on the horizon. And I don't work doing vaccine trials, so I actually don't work with drug companies per se, and I luckily have no conflicts of interest to report. I threw this one in for Steve because this has to be about one of the most beautiful viruses that you would ever see. I mean, this is an absolutely spectacular picture of a double-stranded DNA virus, beautifully stained here and a huge close-up. But its name is really important. It's the varicella zoster virus. So it does those two things. It gives you varicella chickenpox and zoster shingles. And this next graphic, which was published in the MJA by Tony Cunningham and colleagues, gives a really nice explanation of this. So we're all familiar, or maybe we're not all familiar actually, some of those who are younger healthcare practitioners in the room, with the appearance of varicella in childhood. So we get this virus, it enters through the upper respiratory tract, there's an incubation period, there's a travel to regional lymph nodes, the liver and the spleen, primary viremia, and then the virus travels to the skin and the mucous membranes where it causes all of these little lesions, which is very much what we know as chickenpox. But then from the skin the virus travels down the nerves endings to hide out and live and be latent in our dorsal root ganglia, in our nerve, the base of our sort of nerve roots, and then many years later reactivate. So the other important thing here is just for you all to acknowledge your own virus. You can't catch zoster, it's your own virus that wakes up in you a little bit later down the track. And many, or not many, but some of you may already have had shingles. I certainly know some person in the room who has, and he's not that old. So this is a very fascinating virus at many levels. And this is what it looks like. We've already seen a picture of this, but this is a classic dermatomal distribution, so the area that particular nerve root supplies. It usually manifests as a localised rash. Often there's a pain before the rash occurs, and people can go off thinking they've got a heart attack if it's chest pain on the side of the chest. There's often systemic symptoms, so usually a real flu-like kind of illness and feeling really pretty yucky when you get this. And then the complications include both site-specific disease, depending on which dermatome it affects. And there was a terrible, couple of pictures that I could have showed you. I've got one that's quite nasty, depending on the site that the virus reactivates. And then there's also dissemination to affect really the whole body potentially in immunocompromised hosts. But by far and away the most outstanding complication in terms of morbidity and indeed mortality is post-herpetic neuralgia. So this has variously been defined as pain that lasts for more than either 90 or 120 days, depending on the definition, after the onset of the rash. And the risk factors for developing this, the greatest risk factor is advanced age. Amongst that then, those with severe prodromal pain, with severe pain or rash in the acute phase of the shingles itself are also at greater risk. And this neuralgia can have great impact on the quality of life and can be very refractory to treatment. So management includes antivirals, but it's important that I tell you already before we even start talking about vaccine effects that in the vaccine studies that I show you, about 2/3 to 80% of the participants had antivirals given to them. So antivirals can help shorten the duration, slightly shorten the pain, but they're not a magic fix by any means. And they're required to be prescribed within 72 hours of the onset of the rash, which can actually be very hard by the time you get to the doctor. Some of the other medications that have been used are the painkillers, and they're incredibly complex, the sort of approach to management of pain of this condition. Opioids, tricyclic antidepressants, tramadol, gabapentin, and here's just a graph of the number needed to treat to just achieve a 50% reduction in pain in indeed one patient. So this is a very, very difficult condition. This is a wake you up in the evening kind of picture, but this is a photo of how devastating this condition can be depending on the site where it reactivates. So you'll remember from your anatomy, this is the first branch of the trigeminal nerve, and you can see this involves ulceration of the cornea and is absolutely terrible for this poor lady. Again, the impact on quality of life of herpes zoster is quite significant, and affects all 4 health domains, so the physical, psychological, functional and social health domains. And there's a correlation which you can understand between the increasing severity of pain and greater interference with daily activities. Some people experience permanent loss of independence from this condition. You can see here from this particular graph, this is taken from a French study which was published in Johnson, and it says here what normal people experience is the average score quality of life index. So that's where most people in the French population are sitting. If you get acute herpes zoster, you're way down here, and this is significant in terms of a difference. If you get complicated zoster, so perhaps complicated by a site like we just saw, you're down here, and if you get post-herpetic neuralgia, you're way down here across all of these different domains. And this can push some people down what we call the clinical frailty score. So here we are, I'm sure most of us in this room are pretty fit. We're all working, but you can be pushed down from a fit well or managing well score right down, through the cascade to being severely frail or very frail, depending on where you are and your age and the severity of zoster and post-herpetic neuralgia. So some more sad news for the night. We reached our peak with our immune system sometime around our early 20s, late teens. So our immune system was on fire right then, and it's all been downhill since. And with this immunosenescence comes a couple of things. So firstly, we have an increased incidence and severity of infections, and we unfortunately also have a reduced response to immunisation. What does that mean in terms of this virus? So one of the common things that I'm asked about was, okay, so your antibody wanes, but hang on, I thought you were sort of had antibody for life and we rely on that. Well, you do in fact have antibody for life after a natural varicella zoster virus infection, but it's not the antibody that you need to be able to deal with this virus. What you really need are virus-specific T cells, and these are the T cells here plotted on the side. And here's age plotted along here. And this is a really important graph because it shows you get naturally infected with the virus, your T cells turn on and they recognise the virus. And then you may get exposed again, you have a bump up in your T cells, maybe your virus even kind of partly reactivates without you knowing. It pops its head up, but doesn't cause you any problem. And then your T cells are all happy, they're above this so-called zoster threshold. When your T cells decline, that's when you're in trouble and you're possibly likely to get herpes zoster, and that's typically with advancing age or with induced immunosuppression. Vaccination boosts your T cells, and indeed an actual episode of herpes zoster boosts your T cells. It also boosts your antibody level, but that's not really the most important thing here. So let's look a bit more at this about, with respect to age. And this was work done in 1975 when I was 10, just in case you hadn't worked out how old I was. And in fact, this is really still very accurate today. So here's the step up in the rate of zoster per 1,000 people by age and in post-herpetic neuralgia. This was done in the UK, but the numbers are pretty similar actually across the number of countries in which these studies have been done. And indeed in the shingles prevention study, which was the hallmark phase 3 study of the vaccine that we're all about to start using next year, these were the incidences per 1,000 person years in the control, in the placebo arm. So this was one of the best studies to actually plot out, the incidence of herpes zoster because they did such incredible surveillance during the study and of post-herpetic neuralgia. So remember, if you've had chickenpox, you're at risk of zoster. So probably everybody in this room is at risk of zoster because the seroprevalence or the likelihood of having been infected is more than 97% once you're over 35. The cumulative lifetime risk of zoster is about 20%. So 1 in 5 of us at least is going to get this. 70% of all zoster cases are in those greater than 50 years of age, in case you weren't feeling your age already in this talk. And the recurrence is said to be rare. Now it is rare, but actually that's not rare when you think so many people are getting it. A number of people will be having second episodes, maybe third episodes, and we think there might be something genetic to this, but it's still a little elusive as to why that is. Over 150,000 new cases in Australia annually, and at least 1 to 3% of those cases are hospitalised. And if you look into hospitalisation data and the coding, we don't really have a lot of detailed kind of clinical studies to validate that coding, but it's actually more than that if you look into the coded hospitalisations. So what about this complication of post-herpetic neuralgia? Well, 15% of all of the people who get zoster will actually then get post-herpetic neuralgia, so that's significant. And if you're over 80, your chance is higher of developing post-herpetic neuralgia if you do indeed get zoster. And again, a large number of the hospitalisations, so the most pointy end of healthcare utilisation for this condition, actually have post-herpetic neuralgia. So people will often ask, is the incidence of zoster going up? And you may recall that one of the arguments against introducing chickenpox vaccination was that if we have less virus around in the community, we may not get that immune boosting of older people who are latently infected. Well, we haven't really seen that pan out. There's no evidence around the world to say that we're seeing an increase in zoster in the elderly because of chickenpox programs. But we are seeing an increase. And so we're seeing an increase in countries that haven't introduced chickenpox vaccine, like the UK, in countries that have, with lower uptake than us, like the US. They certainly had a lower uptake for a long time. And in this country, even before we introduced the chickenpox program. And this is reflected in this particular graph from a publication by Ryan and McIntyre just this year, where you can see this is actually plotting out antiviral prescription rates in the Beach GP research network, and you can see that they've risen over time. Certainly were going up before the introduction of the program in late 2005. And as you can see here, this shows the age-related effect with the with the different levels of prescription by age. Now, this is another earlier publication, in fact, from that same network. And the reason I show this is because it already shows you some preliminary data on how GP consultations from chickenpox are going down, but you can see this green line showing the trend in increase in herpes zoster consultations. This is a complicated table. You don't have to really look at it all, but it is to say that when we were doing the analysis of this for the ATAGI Working Party, we found that in fact Australia in this latest analysis is said to have some of the highest rates in the world, albeit not many countries in the world have really looked closely at zoster, and it's quite a hard thing to study because many of the patients who get zoster don't in fact go to hospital, and so it relies on having very good surveillance in general practice. Interestingly, our hospitalisation rates aren't rising. They've stayed at a pretty kind of flat level, although they are, quite significant and obviously highest here in the over 80s. This might be for other kind of confounding factors, which is that, over time we're trying to treat more people as outpatients, or indeed we may be keeping, some people in things like hospital in the home, or not getting them to hospital in the first place. Okay, so let's get on to the vaccine, because that's why we're all here, and it is a very interesting vaccine, and as you've heard from a number of speakers already today, it's coming to us soon. So this is a live vaccine. This is a live attenuated vaccine. It's made of exactly the same vaccine virus that the chickenpox vaccine that you're all using out there is, from a little boy whose last name was Oka, who was born in Japan, and that's where that same seed virus strain came. And it's attenuated, so it's weakened, but in the zoster vaccine it's actually 14 times more vaccine virus than there is in the chickenpox vaccine, and that's to overcome that antibody that we have pre-existing, but to boost those T cells. It is licensed for use in adults over 50. It's given as a single dose. And the efficacy studies, which I'll show you some more data on, basically show that it's a partially efficacious vaccine. And I want you to think about that, because a lot of the vaccines we may be used to dealing with, like, measles or some others, are really high up there in terms of efficacy, over 90%. This is a vaccine that's going to cut your chances of getting zoster by about half. So it's not going to stop zoster in everybody. But remember, we have a lot of zoster. It's a bad disease. So even reducing the risk of getting zoster by 50% is a good thing. And the protection against post-herpetic neuralgia appears higher, so cutting your chances of getting PHN by about 2/3. But that efficacy does decrease with age. So right there you might be able to understand the conundrum that our risk increases with age, but efficacy declines with age. So it's quite hard to pick when to start the program, and there's been a lot of thinking around this. Because it's a live vaccine, it's contraindicated for use in persons with immunosuppression. And here is the current wording in the handbook. Dare I say it, I'm going to suggest we might even write more. But it says that you can potentially consider vaccination on a case-by-case in patients under, taking low-dose, agents which might be partially, immunosuppressive. But I think this is an area that I'm going to come back and discuss more at the end. So here, in fact, is a plot of the efficacy of Zostavax. And so it's important to show you that it's only in this first section that you can see any data on the 50 to 59-year-olds. So there has been a study in 50 to 59-year-olds, but they don't get post-herpetic neuralgia often enough to be able to enable the trial to report on post-herpetic neuralgia as an outcome. So in fact, we don't know how it impacts on post-herpetic neuralgia in the 50 to 59-year-olds. I'm sure it'll be effective, but we don't have an estimate there. And then you can see here, there's the other three age groups, 60 to greater than 80, and this third measure with burden of illness is just kind of a composite measure saying, how bad it made you feel. And one of the striking things here is that, and which people have made quite a bit of, is that if you're 70, greater than 70, the impact on post-herpetic neuralgia as compared with the 60 to 69-year-olds was quite similar. So in fact, maybe the vaccine somehow continues to protect you better against post-herpetic neuralgia, as you get older, than it does against zoster per se. So you might get zoster, but you might not get the post-herpetic neuralgia. Now again, that really needs to be borne out. But look at this drop-off here in the over 80-year-olds. So in fact, once you're over 80, there were fewer patients in the study, but we think the vaccine is less effective on a population basis, certainly, although individual effect might still be there. So we've heard a lot about this. You would be aware perhaps that the vaccine's now available on private prescription. It's actually been registered here since 2007, so you might have heard other talks about this in the past, but there was a global shortage from production in the company, and that made it actually very tricky to get any supply for a number of years. I think what I'm going to say to you, and this is probably a plug and some support of the people who are already working on this at the departmental level and groups such as CDNA and the surveillance branch, is that we are going to need really clever and sensitive epidemiologic surveillance of the impact on herpes zoster and post-herpetic neuralgia to understand, whether we're getting our bang for our buck in this program coming up, because, it's a big expenditure by government, and it's tricky to be able to assess both of these disease outputs. I haven't shown you really any data on post-herpetic neuralgia in Australia. So the GP data doesn't capture that well, the hospitalisation data doesn't capture it well, and there's a lot of people thinking quite cleverly or, thinking quite hard at the moment about how we can work on post-herpetic neuralgia. How long does a single dose last? Well, at least 5 years, but we're not really sure, because that third bar there tells us, it suggests that there's about a 20% effectiveness between years 7 and 10, but that in fact was a study that was just observational without a control group. So really the estimates are only significant out to about 5 years. Does it work to prevent recurrences in people who've had who've had zoster in the past? Again, we don't know, but we do know it's safe to give if you've had zoster. So there's a few questions remaining there. And is it safe? This is a question at my heart, and I think it's at the heart of lots of people. It is safe. The trials done in very well clinical trial attendees showed that it was a very safe vaccine, quite a low rate of adverse events and quite comparable to the placebo. But these were well elderly. The real population that we're going to be giving this vaccine to, many patients are on different sort of treatments. This is going to be the first time that we're giving a live attenuated vaccine to the elderly. If we've inadvertently given a flu vaccine or a pneumovax to someone, or we've given them, we don't really think about whether they're on, a new monoclonal antibody to treat their rheumatoid arthritis. So this is a really tricky kind of in-between population here that we're going to have to think about. If it was inadvertently given to a very immunosuppressed person, there is a potential risk of disseminated viral disease. So again, very important from a practice implementation point of view, and I think this is where we're going to need to probably expand advice, certainly in letters that will be written and guidelines that will come out with the program, I think are going to really need to address this. And the UK have recently, they've had the program going, in fact, for 3 years now, but they've recently updated their guidance in quite a detailed way to deal with how to kind of approach this in-between group. Just a quick, I'm running out of time, but just a quick buzz through the USA. They've had low coverage, but seeing vaccine effectiveness in post-marketing. The UK, they've gotten up to 53% of their 70 and 79-year-olds being covered, and haven't been able to show us anything from an impact assessment yet. In the last sort of 30 seconds, I'll mention one vaccine that's coming up, but not registered just yet, and this is an activated vaccine. So a study of this vaccine has just been published in the New England Journal. It's produced by GSK, and it's a recombinant VZV glycoprotein. So this is very, very interesting, because if you look at the figures here, the reported efficacy in 50 and 60 up to 69-year-olds, and even in the few participants over 70, is very high at about 98%. So basically, that's an exciting vaccine, which I'll skip over. These are my last few slides, just to make you excited that now in the 2000s, we're moving out to being able to only use canes when we get to 90 plus. What I'm really hoping is that this vaccine and lots of other vaccines that are coming down the pipeline in the elderly are going to help us dance rather than bend over crossing the road. And I'd like to thank particularly Sanjay Jayasinghe for help with slides tonight.
Thanks, Christine. I think the HPV story in Australia has really been a very exciting one, and one which Australian research at all levels has been intimately involved in. And Associate Professor Julie Brotherton's going to tell us some more about that today. She's a public health physician and medical director of Australia's National HPV Vaccine Program Register. She's a medical graduate from the University of Newcastle, and has a master's degree and a PhD from the University of Sydney. So looking forward to hearing from Julia about the HPV vaccine program. Thank you.
Thank you. I think we're running a little bit over time, so I'm going to try and be quick. So I'm going to talk to you with sort of a shamelessly Australian focus on our uptake and impact data about the vaccination program. But I did want to talk a little bit at the end about where we might be going, because I think there are some opportunities to increase the impact of the program through using possibly 2-dose schedules, or and also bringing you up to date on the new 9-valent HPV vaccine. Before I do focus down on Australia, I did just want to remind us all that Australia has been a real world leader, but we are still having issues with availability of this vaccine in the places that really need it. So this is a map of countries who had a national immunisation program with HPV vaccine as of last year, and at that time there were 58 countries. There's now 65. And it's looking pretty good, but you'll notice, I don't know if I can get that to work, that, some of our neighbours in Asia, like PNG, and the whole of Africa are glaringly absent, and we know that these are regions that have some of the highest burdens of cervical cancer. So despite the fact that Gavi has negotiated a vaccine price of less than $5 a dose for this vaccine, it's still not reaching some of the people who really need it. So I think, again, we need to count our blessings about how lucky we are, and also to continue to advocate for other people in the world who really need these vaccines. So just a quick reminder, this has been our national HPV vaccination program, which of course has used the quadrivalent HPV vaccine, and just a reminder that at the moment we recommend 3 doses over a 6-month period, and it targets the HPV types 16 and 18, which are the nastiest of the cancer-causing types and cause about 70% of cancers, and about half of those pre-cancer lesions that we're looking for on Pap tests, and 611, which causes genital warts. So our program started in 2007, and we delivered what really was a massive catch-up program all the way up to age 26. In 2009 it became a routine school-based program for girls delivered in the first year of high school, and then more recently in 2013 the program was extended to boys of the same age with a catch-up up to age 15. And now we've bedded down to what we hope is a nice gender neutral, I hope a routine rite of passage. You go to high school, you get your HPV vaccine to protect you against this cancer-causing virus. Why wouldn't you? And you can see the communications campaigns have obviously changed with the message. So we had our lovely pink program, and I used to enjoy my register logo with a lovely pink flower on it, but now we've gone gender neutral. We've still got a bit of pink in there, but it's very much focused on prevention of HPV related cancers, and we're now mature enough as a community to call it an HPV vaccine, and I think people do largely know that we mean HPV, not HIV or Hep B or anything else, and that really people have come on the journey of understanding about HPV. Now, this is just a snapshot to give you an idea of the volumes of vaccine that we've had coming into the register with the various programs. So obviously the bars at the beginning are those mass delivery programs associated with the catch-up, and the orange is general practice doses, and these are school and community providers. So millions of doses bedded down to just girls, and then of course with the introduction of boys we've seen volumes increasing again. I hope many of you are familiar with this. This is really how we went in terms of that big catch-up program from 2007 to 2009. Really staggeringly high coverage for an adolescent vaccine, first in the world delivery, new vaccine, I think, and also very, very high coverage in young women who had to go to the general practitioner and be vaccinated. This certainly exceeded our expectations of what coverage we would be able to achieve. You will, of course, though, notice that it is difficult to get 3 vaccine doses into anybody, and I have to say that remains a challenge. We also do know that because general practitioners did not have to notify the register of these doses in this population, this is under-notified by about 10 to 20%. So our coverage is actually even better. And I'm sure you'll be able to appreciate that when we move on to talking about the impacts that we've seen, which really have just been so dramatic. So how have we gone since that big groundbreaking catch-up program? Well, we've been going along quite nicely, and this is third dose coverage, so people who've completed the course, and we routinely measure this at age 15, which might seem a strange thing to do, seeing we vaccinate mostly 12 and 13-year-olds, but because the way the program is delivered differs in all the states and territories, because the age you are when you start high school differs, we need to wait till people are 15 to make sure everyone across Australia has been actually offered and had the opportunity to complete the vaccine. And so this is a WHO recommendation that you routinely measure at 15, because most populations have been vaccinated by then. So very stable, around 71 to 72% until recently. So I was extremely pleased to see this coverage finally going up, even if it's just 1%. But we're starting to see lots and lots of work, and I'm sure a lot of you in this room have been involved in it, in improving delivery in our school-based programs. Even more excitingly, when we look at our younger cohorts who are starting to move through, so this is 2013 cohorts now, 12 to 13-year-olds, you can see that we are getting improvements in coverage. And in 2 of the biggest states, so in New South Wales and Victoria, they've actually now hit 80% 3-dose coverage, which is just a phenomenal effort. And I'll talk in a minute about how New South Wales in particular has done that. Let's have a look at some South Australian data. So this is how you're going according to our national register. Now again, this is the age cut point is 2013, and you'll immediately notice it's a little bit lower in 12-year-olds. That's because not all children in your cohorts will have had the opportunity to have completed the course yet. If they were 12 in 2013, they'll be 14 now, so many of them may have only been offered for the first time this year and still not had that 3rd dose. So don't be worried about that. This is exactly why we don't measure it till everybody's 15, because there's this lag time. I think you're doing really well, and I love the way the gap is definitely closing between the 1st and 2nd dose. There is still a drop-off to that 3rd dose, and some of this is under-reporting. So I know in South Australia you often get general practices to catch up that 3rd dose, And when we've compared the South Australian records of distribution of doses to general practice with what we get coming into our register, it's probably only 50 to 70% of doses were being notified. So I think you can be confident that true coverage is at least a couple of percentage points higher. But why is there that big gap? Why aren't people finishing their courses? Well, you're lucky in South Australia, through great leadership locally, that there's actually been a study looking at this that Maureen Watson led. And this actually used the HPV vaccine register to do this study. So using the register to identify people who were apparently still incomplete and basically asking parents to either contact the register if they have actually completed their dose, or go and get the dose if they haven't had it. And if they're not finished the course, let us know why. And interestingly, out of this cohort, about a third of them at this prompting reported a huge number of doses that had already been given. So this is that under-reporting that we're seeing. And of those people who said, well, I didn't know I needed to finish, or I'm still not complete, the main reason they said, obviously, is I wasn't at school that day. Only just more than a quarter recalled getting a letter telling them they had to go and get another dose somehow. And some of them said, you know, it's too hard. I can't get to a doctor. So there are those logistical barriers, and it's these real I guess, practical system issues that I think we're going to need to solve if we're going to close that gap between the first and the third dose. Interestingly, 70% of them said if it was offered to my child the following year when the teams come back, I would accept it. And this is exactly how New South Wales has solved their particular problem. So they had amongst the lowest third dose coverage in the country. And by changing their policy that routinely when the teams go back the following year, they catch up the kids who missed a third dose the previous year, they've closed their third dose coverage gap by 10%. It's quite staggering. So I'm aware other jurisdictions are talking about possibly looking at that system as well. Now, obviously that's an impost on schools and education departments, but I think we need to think about that partnership between health and education and whether we can utilise it to get better population coverage. The other thing that I think is important to remember is that I do think school programs really facilitate equity. So we can see here these are the girls who live in the highest, the most affluent areas and the poorest areas. And you can see in terms of uptake, there's really not much difference. It does become a little bit more disparate by dose 3, but if you compare that to cervical screening uptake, where there's a 20% gradient between our poorest and wealthiest women, this is certainly a way to try and close that equity gap in cervical cancer that we have in Australia right now. Now, moving on to boys. So as you know, this is, I guess, a new program for boys. And this is the coverage that we have again, and this is for males turning 15 in 2014, already at 60%. And you can see South Australia is doing pretty well. Now, this data, of course, is not yet complete, because I believe boys in these cohorts may still have the opportunity to complete that course. And of course, if we look at the actual target age group of the program, knowing that the catch-up boys are probably less likely to accept the doses, we know the older you are as an adolescent, the lower coverage we seem to get, you can see we're doing pretty well. I think this gap will close in time. And this is your data here. So again, you see for the 12-year-olds there is a lag there, so I wouldn't be worried about that. That's just the vaccine courses aren't yet complete. But really doing quite well, and probably in the last year you have gone over 80%. Again, this will be impacted by underreporting in general practice of those third doses. So I think definitely you're on your way, and this is a testament to the great work that you're all doing. So let's talk a little bit about the impact that we've seen in Australia. The first thing I want to mention is, actual circulation of HPV virus. So this is a study that we undertook comparing women attending for Pap tests in family planning clinics in 3 states in the pre-vaccine period versus the post-vaccine period. These are 18 to 24-year-old women. And we took a sample when they were having a Pap test from the cervix to see if there was HPV present there. And unsurprisingly, because basically if you have sex you get HPV, very, very high rates of HPV was detected. And that's true in both pre and post-vaccination periods. What you can see though is that there is a significant decline. There's a significant decline in these high-risk cancer-causing types, and this is absolutely driven by this massive decline in vaccine-specific HPV types. So not all these women in these cohorts were vaccinated, most of them were, but you can see just a dramatic impact on the likelihood of a young woman now having any of those types detected when she comes in for a Pap test. We've done another study recently in Victoria, which is actually recruiting young women actually through Facebook and inviting them to let us to monitor whether they have HPV now. This is actually a self-collected vaginal swab from sexually active young women. And again, most of them have HPV. Well, not most of them, but over 20% of them have HPV. But look at this. Almost no vaccine-targeted types. Any other population pre-vaccine, this 16 bar would be the highest by far. So just an absolute decrease in the amount of circulating virus. So really an incredibly effective program. Now this is really where we're most interested in seeing an impact, and this is on those precancerous cervical lesions, so the high-grade lesions that you're looking for when you're doing a Pap test. And this is data from the Victorian Cervical Cytology Registry, and the arrow there is when the vaccine program came in, and these different lines represent different age groups. So if you have a look at these are the women under 20. You can see that since the program came in, we've basically seen a halving of those precancerous lesions being diagnosed on a biopsy in young women. The 20 to 24-year-old age group happened a little bit later, but definitely down. And I got excited last year by this tiny little, maybe it's starting to go down, and it's not published yet, but look out for this year's data, which will be published very soon, because we are certainly now starting to see a big impact in the 25 to 29-year-olds. So as the cohorts are ageing up, we're getting less and less of these precancerous lesions in our young women, which is just fantastic. And I should note that we see the same thing in our national data, and we see the same thing in South Australia, but unfortunately I couldn't get permission to show you that data because it's not yet published. But trust me, you're doing a great job here as well. Okay. You're probably all very well aware that the other major vaccine impact we've seen in Australia has been a near disappearance of genital warts in young people, and I know my sexual health physician colleagues have been particularly pleased about this, that they don't spend most of their day now trying to remove warts. So you can see this in this graph here, and this is looking at the percentage of presentations to sexual health clinics in a sentinel network around the country diagnosed with genital warts. And you can see very rapid, dramatic impact in young people, and this is the females, and fascinatingly, very, very dramatic impact also up in higher age groups in male partners. And that makes absolute sense, doesn't it, if this is a sexually transmitted infection. If you block transmission from one sex, you're going to give the males a wonderful free ride and a great benefit from their female partners being vaccinated. Yeah, I couldn't understand when people were saying, oh, not giving males vaccine is an equity issue. Well, no, not really, because they're getting a fantastic benefit without having to be vaccinated. They're actually the ones who are winning in this equation. But anyway. So the other thing I wanted to mention was I think we've really learned in the last 10 years that there's other ways that the vaccine is benefiting us other than what I've just shown you and the impact on those precancers of the cervix. We now know that it is effective in males and it does prevent disease at other sites other than the cervix, and the references are there. We now know that it does have some significant, although lesser, cross-protective effects against other HPV types. And importantly, we now know that although HPV vaccines can't remove infection that's there already, they do seem to be able to prevent recurrence of disease in people who've already been treated for disease. And this is probably because it's actually preventing new infection. We know these people are actually susceptible, and if they get HPV, they can't clear it. So they're high-risk people. And so I think this is a conversation we need to have, is should we be routinely offering it to people who've just been treated for a high-grade lesion? And I think the answer is we probably should. So I'm going to try and be quick because I know we're way over time. Just to mention, 2-dose schedules. We now have evidence that if you vaccinate young adolescents, so people under the age of 15 at their first dose, with 2 doses more widely spaced apart, so you're getting a prime boost instead of a prime boost, you get just as good an antibody response. And this has actually been approved for use by WHO last year, and it's being adopted around the world. And this is really the reason why. Now, this is for the bivalent vaccine, but the principle holds for the quadrivalent. The blue and red lines are adult women given the 3-dose course versus younger women given the 2-dose. It's almost identical in terms of the sustained immune response. So why wouldn't you give just 2 vaccines? Easier to deliver, more cost effective. The 9-valent vaccine is now registered for use in this country. It is not yet available, however. And the idea of this vaccine, it's basically the same technology as the quadrivalent vaccine we use, but 5 more virus-like particles against the next 5 most common types found in cervical cancer have been added to this vaccine. And basically what the trials needed to do was, because you can't give a placebo now in these trials because we know quadrivalent vaccine works, so they had to show that the immune response was non-inferior to the quadrivalent and demonstrate efficacy against the other 5 types. And in short, they did this. You'll see this against high-grade cervical, vulvar and vaginal disease due to those 5 types, 97% efficacy. And they did indeed show equivalent GMTs and seroconversion rates to the quadrivalent vaccine. There is a slight increase in injection site reactions, and that's because they had to put more virus-like particles and more adjuvant in the new vaccine. And just to mention, these papers are in press showing equivalent immunogenicity in males, and bridging to adolescents 9 to 15 persists at least 2.5 years, and notably they actually had less injection site reactions than the adult group did. I just wanted to finish by saying I think the policy challenge is going to be, do we implement 9-valent vaccine in Australia? And I'm sure you're all thinking, yes, of course we should. It's better. It prevents small cancer. Why wouldn't you? The issue is, how much better is it, and what price should we pay for that extra benefit? This is US data, but I think it's worth just stepping you through. This is the burden in cervical cancers and all these different types of cancer here due to types 16 and 18. So we've got good protection against these types already with the quadrivalent vaccine. You can see it's the majority of each of those. And the other 5 types that have been added make up a small, but you can see significant percentage, particularly in cervical cancers. If you then have a look at the actual number of these cases, and again this is US data, you can see that the actual number of cases as a proportion you're going to prevent is really probably only significant in cervical cancer. Men are going to get a lot less incremental benefit from this vaccine. And if you put them into a model, and this is a US model again, comparing quadrivalent vaccine with 9-valent vaccine, this is a sort of size long-term impact you'll see in cervical cancer prevention and in these precursor lesions. You can see for women it is quite substantial over the long term, and therefore probably worthwhile. Whereas if you look at other cancers, so non-cervical cancers, these cancers occur at a later age. It takes much longer to reap the benefits, and you can see the absolute benefits are a lot smaller. And it's because of this that we need to think really carefully, how much are we prepared to pay for that much smaller gain over the huge benefits we're getting from the quadrivalent vaccine already, particularly in men. What's interesting is that this analysis from the US actually showed that the US going from quadrivalent to 9-valent vaccine is cost saving in their context. Now, you wouldn't have intuitively said that, but it's cost saving at a price of $13 more per dose. So pay more, you actually save money. And the reason is, apparently, in the US, treatment of these lesions is incredibly expensive. So that's what's driving that, and it's going to be different in our country. So we need to very carefully consider how much we as a society are prepared to pay to get the extra benefits of what I have no doubt is an excellent vaccine and certainly can prevent more cancer, but we need to think about its role in our healthcare system, and also we're also waiting for evidence from 2-dose trials of this vaccine to get the most cost-effective approach. And that's what I want to say. Thank you.
Okay, we are a bit over time, but I think we should still go for our panel, perhaps for 10 or 15 minutes. So I will ask the panellists to come up and for the audience to think of some really tough questions for our panel, particularly for Chris. And so I'm not going to take a question. The first question has to be for Chris, so please think of a really good question.
Hang on, I've got to get the phone out.
There's a question over there, I think.
And yes, my question is for Chris. Thank you, Chris, for your letter. I did note it was personally signed, so thank you. My question is, and you may like to phone a friend.
Yep.
If the Australian Immunisation Register is expanded and providers are going to be able to record all of the vaccines given to children up to 19 next year, will the school program vaccines that will be recorded then on that register, will that register talk to the new expanded HPV register that will start in 2017? And I have a second question. Are providers going to get a notification payment for all of the vaccines that are going to be recorded to the registers?
I'll make sure you get another one of those letters very soon. Look, I'm going to have to. I don't think I can answer those the questions, but others might.
Yeah.
Thank you.
I can help a little bit. My understanding is that for next year, the HPV vaccine won't be included in the calculation of whether a child is complete. The plan will definitely be that the two registers will talk to each other, and while the full whole of life Australian Immunisation Register is being developed and built, the plan will be in the interim that any doses that come from general practice up to that register will be sent sort of in more of a manual process up to the school's vaccine register or the HPV register. So there's definitely plans that they will eventually have seamless electronic communication, but I think there's going to be a period of growth and development while both of those new registers are developed and bedded down, where we will need to, I guess, work around until all the systems are in place. So it's definitely being considered and thought about.
Just the other thing to add is remember that the eligibility only pertains to the vaccines that are due up to the 4-year schedule point. So it doesn't actually pertain to the adolescent vaccines for the eligibility for the family tax benefit too. So that's, I always have to keep remembering that myself because I keep thinking, but no, that's the case for now.
And while I'm no particular expert, the answer is yes to your first question, no to your second, I reckon.
There's a question over there.
I just had a question. The girls, I work in general practice, the girls at the desk often get very cranky parents coming in saying, you haven't notified of our immunisations. So I'm just curious, if parents don't get paid because they decide not to immunise their child, what sort of money are we looking at it? Because the response the girls at the reception get, they think the parents get $1 million.
So the question is really what sort of money is someone foregoing by not immunising their child and therefore not getting paid? So no pay, no jab. How much is the no pay?
Well, again, my friends here, I don't have to phone anyone. I've got lots of friends here, but I'm not an expert on the payments of family tax benefit A and the child care rebate, and the because they're means tested, so not everyone gets these things. Obviously, the loss of these payments will impact on the people who can least afford to lose the money, I think is what it is. So I guess clearly the intention of government was to encourage then by the use of this method to get the vaccination and therefore not lose the payment. Look, about 6 months ago I did know the numbers, but I haven't retained them. Does anyone else know? Do you remember, Julie?
There's been different reports. It's thousands, and I think the last thing I saw was about up to 11,000 as a maximum. But it is means tested, so it would be anything below that as well. 2 of the payments are means tested, the family tax benefit Part A supplement and the child care benefit, but I think the rebate is not means tested, but that's a smaller amount.
And I guess the only other thing is to say that it's assessed every single year. So, I mean, I think that window period that we heard about is going to be important to be able to get whoever's at the desk or the practice nurse or whoever to delve into those records and really go through it with the parent. But then each year the parent, gets reassessed again. So that kind of larger amount is an amount accrued if you really do decide not to be vaccinated and not to be up to date. So that's not a one-off, once a year type amount.
My question is more of a comment to you, Julie Lesk, and I do need Professor Chris Bagley to be paying attention as well. Over here. In regards to your paper, generating confidence or in immunisation, I think the answer is women to have more continuity of care providers during their pregnancy. And that way you're generating that trust that you said we had to prioritise, as well as the home visiting benefit of the continuity of care, a midwife. And your touch point of influence as well was the antenatal care and the primary care provider. So a continuity of carer, midwife, being the lead maternity carer for pregnant women, is an answer to many of your issues regarding the confidence, communicating that with the immunisation, and so then we would have a greater number of immunisation rates during the pregnancy.
I'll take that as a comment. I've been asked to say by the Chief Medical Officer. Look, I thanks for your comment. I agree, and midwives are increasingly engaged with vaccination through maternal vaccination and of course through providing neonatal Hep B. So, and I'm a former midwife, and it's very important that we positively engage midwives. Generally, they have high support for vaccination. They are more likely to have specific concerns. Kerry Wiley, who's been reviewing the literature with Katie Atwell on this issue, they've found that there are definitely concerns about immunisation among midwives, despite a general level of very high support. So, and they do want to be more engaged and more updated. So it's very important that we engage midwives from the highest level, from the Chief Nursing and Midwifery Officer right through to midwives working at the coalface.
Okay, other questions? There we go.
This is probably a question for Chris as well, and I haven't had a letter yet. We work in general practice and we're seeing a lot more people asking about meningococcal B, and we're giving Bexzero. Is that likely to be on the schedule soon?
Well, I can start because it's one I can answer a bit of. I think it's the third time that's been to PBAC, the Pharmaceutical Benefits Advisory Committee, and on each occasion it's been knocked back on the basis of cost versus efficacy, and so the case has not been proven for this to be on the National Immunisation Program. I reckon I got that right. I did. Well done. Make a note.
But perhaps Helen or Christine, did you want to just comment, or Ross, on that? Because it has been heavily debated, and I mean the impact to an individual or a family is enormous. Finding cost-benefit analysis across a whole population has been difficult, but it has been a really debated and it is actually quite a good vaccine. So Ross, do you want to comment on that?
Yeah, certainly, so my chair of ATAGI had on, we've paid a lot of attention to that vaccine, given a lot of advice to PBAC and to the company. So our view from a public health perspective is the disease burden is in infancy and adolescence, and we'd like to see a program that targets infancy and adolescence. The crunch comes, and it's in the publicly available information, is about the cost versus the benefit. There are a number of uncertainties about the vaccine. It's an unusual development of a vaccine. It's not the common way that we've gone about developing vaccines. It's quite an exciting strategy for vaccine development. But what has come out with it is an endpoint that's actually a correlate of a correlate, rather than a demonstration of clinical benefit per se, because this is a serious but rare disease. So it's a very tricky space from a vaccine perspective, especially when it comes to cost effectiveness. So the issue is always about the uncertainty and how much the country is willing to pay for that uncertainty, and how much the company is willing to bend on that space. So those things always become a pretty tense space. We sit there with a public health hat on, and we'd like to see the meningococcal B vaccine be available for infants and adolescents. It's a cost thing currently, and discussions are still going on, so I'm still involved in those discussions, so it's not over yet.
And can I just add, I think one of the difficulties we've had is having really good data. So we do have data on deaths. We have very minimal data really about cases that recover, children that recover. And so what we really need is accurate long-term data on what the sequelae are like for those children and their families. So that's certainly something we're working on within our research unit, to try and get some really good, robust, detailed data on sequelae of disease that can then be used in better cost-effectiveness analyses.
And to add, I always believe in dialing a friend too. So up until a little while ago, there was no other country that was using this vaccine in its national immunisation program. So it's really important to be aware of that. But the UK have made a decision to go ahead and use this vaccine for infants. And interestingly, they've just also said, we're going to do it in a 2+1 schedule. So instead of the 3+1 that's currently recommended. So the upside, if there is one here, is that we'll be able to learn from the UK, hopefully reasonably quickly, as to how that vaccine's working in their public health program, and that'll give further evidence to be able to keep looking at it.
Thanks, Christine. At the back there.
Hello. My comment is to Julie. You used a line earlier that our high school students are our future breeders, and in fact I use that comment quite often, and presented a life skill to some high school students in Queensland in 2013 with that particular line, in that I asked the school, could I present something on vaccinations to our future breeders, and they embraced that really well. So my question to you is, who do we rally to use that line, because it was really taken up quite well with the Queensland students in Year 12?
I don't know the answer to that. I don't work in schools. I think I'll pass that to people who are a bit more engaged with schools, and you probably know the answer if you've been working with schools.
It was only, we used to present all sorts of things to the Year 12 girls, but we actually used that line, you're our future breeders, and they really liked that idea.
Well, certainly there's room for it to be included in the high school science or biology curriculum at least. And Robert Boy's doing some work in developing some curriculum to put into schools, but they're crowded curriculums, and it's going to be an uphill battle there. I don't know if any of my colleagues want to make a comment, but it's an idea that we need to test out, really. Engaging students in a positive way and educating them about the importance of vaccine and getting them early when they're formulating their views might help.
I mean, it's fascinating to me that we deliver vaccines in schools and we cannot get education about the vaccines the children are going to have into the schools. It's,
Perhaps that we can direct that to Chris as well. Yeah.
Yeah. I mean, I actually.
I think it's a real issue. Why couldn't we? Why shouldn't we be able to vaccinate? Educate about vaccination.
The
in schools?
reality is that every jurisdiction is working as best they can within an education setting, when education has no formal role and vaccination of their students is not one of their KPIs. We are an inconvenience to them in many ways, and I think until it's a true partnership, that this is about our students' health and well-being, and that I think that the school vaccination rate should be published on the My Schools website, and that we need to have an ownership of the issue between health and education from the very highest level. Until that happens, I think, we can't get immunisation discussed even when we're vaccinating kids in schools. So I think it is an ongoing battle on many fronts in every jurisdiction.
Okay, any other final questions? Because we have now gone over time, but we have a few more minutes, so there's a question there.
I had a question for Christine about Zostavax, talking about cost effectiveness. I just wonder if you could talk us through why it's given to 70 plus and not 60 plus. From what I understood from your data, you said the effectiveness against Zoster was like 30% and 66% against post-herpetic neuralgia in the over 70-year-olds. Why wouldn't we give it to the 60 plus year olds for free and prevent more Zoster? I know it's a cost-effectiveness answer, but I'm just interested in the way you see it.
Yeah, no, it's not really. I mean, I think it's been really significantly debated, and so in fact, I'm not sure whether you're aware, but when the vaccine was first available, the company took it to the NIP, and in fact, it was recommended for use under the NIP for 60 years and above. Now, that was really interesting. That was back, in 2008. And then what happened was that there was actually no vaccine supply. And they couldn't fulfil an order, so it couldn't go on the NIP. And basically that recommendation just sat there for 5 years. Now, what happened in that 5 years is the SPS, that was based on the initial study that only went out to 3 years. The next study, called the short-term prevention study, showed that there was pretty rapid waning. And then the final study showed even less effect, coming out to 7 to 10 years. So basically, there's been, in that 5-year period where the PBAC first said, it'll be cost effective from age 60, this new evidence has come in to say it works better in the 60-year-olds, but it wanes really quickly. So in fact, that effect is likely to wane probably down to baseline of no effect, although we can't be sure, by the time you're 70. And then when you're 70, you're entering that peak age of when Zoster is in fact the worst. So it was a real balancing act between just trying to find when the best time to get the best effect was, balanced both on that efficacy and on your risk and on the duration of protection of the vaccine. And in fact, the UK, as I think I showed, have also gone with the age of 70. The US have just sort of said, give it to everybody greater than 60, sorry, it's a bad accent, but they also kind of, with that strategy, they don't get good uptake. They're kind of targeting too many people. So it was really closely looked at and went back twice to the PBAC just to balance that optimal age.
No, thanks, that's helpful. And we could give one dose at 60 and one at 70.
Well, you might be able to. But that hasn't been put forward yet. And again, it's about having the data to say that would you get that equivalent efficacy giving it the same vaccine 10 years later, and those studies haven't been done yet. But watch this space.
Yeah, no, thanks, that's good.
Okay, I think on that note we might stop, and I'll just ask Helen to just say a few last words.
Thanks very much, and I really just want to say thanks to everybody. Thanks so much for attending. I know it makes it a long day, but thanks so much for such active participation, such great questions. Thanks very much to all my helpers, particularly my team, so within Virtue and also the Robinson Research Institute, certainly Laura and Sophie, who are not here, who helped so much in preparation. But especially to the chairs and speakers, especially those who've travelled interstate, and of course our great partners who really make this happen, and without them we couldn't put this on. So again, to SAMRI, to SA Health, to the Robinson Research Institute and the Women's and Children's Health Network. So thanks very much, and hopefully we'll see you.
Something over there.
Sorry. Oh.
Evaluation form.
Evaluation form. Thank you, Susan Lee over there. Please complete your evaluation forms, which will be collected somewhere on your seats or wherever you like to leave them. And hopefully we'll see you all again next year. Thanks very much.